67% of prescription histories already contain at least one error before a doctor writes a single new order. Place an elderly patient in that system on multiple daily medications, and a routine admission becomes a high-stakes gamble. Infections, falls, misdiagnosis. Hospitals hold traps. Most seniors never see until it is too late. 5 keep showing up again and again, and the first can start doing damage the moment you walk through the door. When an older patient enters the emergency room, staff often rely on memory or outdated databases to compile a medication history. This treats memory as the only source of truth. 67% of these initial prescription histories contain at least one error, and 40% of those mistakes occur during the reconciliation process itself. When high-risk medicines are involved, a small handoff miss can quickly lead to severe harm. 82-year-old Ruth avoided this trap. When she was admitted, her family brought in her actual pill bottles and a detailed list, including all over-the-counter drugs and supplements. This physical verification allowed a clinical pharmacist to review her chart and catch a duplicate anticoagulant order before it could cause a life-threatening bleed. To stay safe, request a pharmacist-led medication reconciliation immediately upon admission. Bring a current medication list along with your physical pill bottles and confirm that all allergy information is written clearly on your chart. Ask the admitting team if any newly ordered drug duplicates or conflicts with your home regimen, and ask which medicines carry the highest risk during your stay. Before any dose is given, repeat back exactly when and how the medicine should be taken. Inside the hospital room, the physical environment presents a direct threat through the lines and tubes inserted into the body. Every day, an indwelling urinary catheter remains in place. The risk of infection rises by 3 to 10%. A case control study of 7,295 elderly hospitalized patients linked these catheter-associated infections directly to worse clinical outcomes and increased mortality. Hand hygiene failures at the bedside remain a primary driver of these preventable events. To stay safe, ask every visiting staff member to sanitize their hands before they touch any tubing or initiate physical contact. Treat any lingering intravenous line or catheter as an active risk that must be medically rejustified every 24 hours. Ask the bedside nurse directly, is this device still necessary today? If isolation or mask signs are placed on the door, confirm the exact precautions in plain language. Watch for lapses in routine care, such as unwashed hands or resting tubing on the floor. If you observe infection control steps being bypassed, request to speak with the nurse manager or contact the patient safety office. Actively managing these lines prevents silent infections from taking hold. About 14 million older adults fall each year in the United States. Nearly half of hospital-associated falls result in serious physical injuries, and roughly 11,000 deaths annually are directly tied to these incidents. These injuries are rarely the result of bad luck. Instead, they are predictable failures of environment, medication, and proactive planning. 79-year-old George barely avoided becoming one of these statistics. Before a planned walk down the hallway, he was given an as-needed sedative to calm his anxiety, but the staff bypassed a formal fall risk assessment. Left alone in a dimly lit room, disoriented by the medication, George began to climb out of bed unassisted. Only a last-second interception by a nurse entering the room prevented a serious impact on the hard floor. These dangerous slips happened due to a mix of sedating medications, cluttered pathways, poor lighting, and delayed physical assistance. To stay safe, demand a formal fall risk assessment immediately upon admission. Always ask if any newly ordered medicine causes drowsiness or instability before you attempt to stand. Keep your glasses, hearing aids, and the call button within arm's reach at all times. If you feel unsteady, request a walker or other assistive device. Ensure the bedside floor path is completely clear of clutter and medical tubing before taking a step. Insist on a physical staff assist rather than relying on a bed alarm. which only sounds after you have already started to move. Finally, secure a structured mobility plan before discharge to guarantee your safety continues at home. Nearly 17% of older adults are readmitted to the hospital within 30 days of discharge. These return trips are costly, at an average of $15,200 per readmission, and they are frequently caused by confusing, jargon-heavy instructions. Evidence shows that structured transitional care models like Project Red reduce this risk, bringing readmission rates down to 8%. To stay safe, demand a written discharge summary before leaving the ward. Confirm every medication change in plain language, verifying exactly which home medicines to stop, which new ones to start, and which doses to modify. Ask for a written list of red flag symptoms that require immediate medical attention, and secure the exact date, time, and location of your follow-up appointments before you step out the door. Ensure a family member, caregiver, or patient advocate is present to hear all of these instructions. This advocate acts as a safeguard during a highly stressful transfer of care. Have them record the names of the treating clinicians who managed your stay, along with a direct phone number to call if your condition worsens at home. Finally, use the teach-back method. Put the entire home recovery plan into your own words to verify your understanding with the nurse. If you cannot explain the instructions clearly, ask the staff to rewrite them until you can. When an older patient experiences a sudden health shift in a hospital bed, a dangerous psychological bias can take over the medical team. This is diagnostic overshadowing, commonly known as the just old age trap. Every year, more than 7 million misdiagnosis errors occur in United States hospitals, and seniors bear the brunt of these mistakes because their symptoms rarely look like the textbook examples. An older adult fighting sepsis often will not run a fever. Instead, they might simply become sleepy, weak, or slightly confused. Older women experiencing a heart attack rarely feel classic crushing chest pain, and they are far more likely to experience sudden shortness of breath, unexplained fatigue, or nausea. When these subtle shifts occur, busy staff often dismiss them as normal aging or dementia. But the golden rule of geriatric medicine is clear. The critical question is never how old the patient is, but how rapidly they have changed from their baseline. To protect yourself or a loved one, you must act. Report any sudden confusion, loss of appetite, or physical decline to the nurse immediately. Do not accept vague explanations. Ask exactly what diagnostic tests are being ordered to rule out acute infections or cardiac events, and demand the clinical rationale behind every major treatment decision. If the bedside team brushes your concerns aside, escalate immediately. Ask to speak directly with the charge nurse or the attending hospitalist by name. If answers remain evasive and the patient continues to decline, invoke the hospital's rapid response protocol or contact the patient advocate office. Use a clear, firm script. I am noticing a sudden, severe change from baseline, and I need a physician to evaluate this immediately. You have the right to be heard. Insisting on a formal clinical assessment can stop a silent, life-threatening crisis in its tracks. Modern medicine can save lives, but a hospital bed is never a place to lower your guard. As systemic pressures rise, active advocacy is no longer optional. It is your strongest medicine. Stay alert and stay safe. Share your hospital safety tips in the comments below.